We've got an incredibly dense amount of clinical data to get through today, so here's the game plan. We're looking at the post-op fever timeline, managing burst abdomens, surgical site infections, the 4 wound categories, preventing infection through proper prep, and finally, perfecting theater protocol. To make all of this really stick, we're going to structure it exactly like a chronological patient journey. Sound good? Let's go.
Section 1. The post-op fever timeline. Diagnosing by the day. Because when your patient spikes a fever, your biggest clue isn't actually the temperature itself, it's the post-op day.
This timeline is brilliant because it illustrates how complications predictably unfold. Day 1, the most common culprit is atelectasis, that collapse of the basal alveoli. We aggressively tackle that with an incentives barometer and chest PT. Now, by days 2 and 3, if that atelectasis isn't corrected, boom, it turns into pneumonia. We also see UTIs peaking here, which is the most common hospital-acquired infection, by the way, along with superficial phlebitis from IV cannulas. Moving to days 3 to 5, that's when surgical site infections and deep vein thrombosis enter the picture. Day 6 is the absolute nightmare scenario, a burst abdomen. And by day 7 and beyond, we're on high alert for deep space intra-abdominal abscesses.
So, zooming in on that day 3 to 5 window, specifically the looming threat of DVT. The data is crystal clear here. Pharmacological methods, like low molecular weight heparin, absolutely crush mechanical ones in terms of superiority. But hey, mechanical methods are still a must. Early ambulation and pneumatic compression stockings physically prevent venous stasis in the legs, which literally stops those clots from forming in the first place.
All right, let's fast forward to day 7. If your patient is suddenly spiking a fever with chills and rigors, you've got to suspect an intra-abdominal abscess. And the physical location? It depends entirely on gravity. If they're supine and bedridden, fluid naturally pools in Morison's pouch, the hepatorenal pouch. But if they're up and walking around, gravity pulls it straight down into the pelvis or pouch of Douglas. A classic red flag for a pelvic abscess is pelvic diarrhea. The patient is passing stool frequently, but honestly, it's mostly just mucus irritating the rectum. Diagnosis and treatment? You need to order a contrast-enhanced CT scan immediately and treat it by draining with a pigtail catheter. Section 2. Managing burst abdomens when the rectus sheath fails. Let's rewind just one day to post-op day 6, where a burst abdomen or wound dehiscence becomes a terrifying surgical emergency. The real trick is spotting this before it's visually obvious. The classic telltale symptom you absolutely must memorize is the salmon fluid sign. If you see a large amount of this pinkish, serious salmon-colored fluid abruptly leaking from the abdominal wound, the underlying rectus sheath has completely failed. At that point, the bowels might literally be exposed right beneath the skin. And listen, you do not have time to prep for a perfect closure right then and there. You have to immediately stabilize the patient with an emergency Eurobag or Bogota bag laparotomy. You're temporarily covering that exposed bowel with a sterile plastic bag, suturing it directly to the skin with a cutting or reverse cutting needle. Only, and I mean only, once the patient is stabilized, do you head back to the theater for definitive management. That means meticulously resuturing the rectus sheath using strong, non-absorbable Prolene sutures. What's wild is how much your specific surgical technique directly dictates this risk. To lower the chances of a burst abdomen, you really want transverse incisions over midline ones, elective surgeries instead of emergencies, and interrupted sutures instead of continuous ones. Also, keep those tissue bites small, like 1/2 centimeter. But here is the absolute kicker. You must ensure your suture thread length is a minimum of 4 times the length of the wound. Anything shorter just cranks up the tension and the risk of cutting right through the tissue. Moving on to Section 3, Surgical Site Infections, Tracking the Contamination. We're looking at SSIs, which, remember, peak around post-op days 3 to 5. These can pop up superficially above the fascia, deep below it, or right down in the organ space. The medical terminology here is incredibly rigid, so pay attention. An infection only technically counts as an SSI if it happens within 30 days of a procedure. But, and this is a huge but, if you placed a permanent implant like a joint replacement or a hernia mesh during the surgery, that window of liability blows up to a full year. To grade the severity of these, we use prognostic scoring. You've got to burn the ASAPS wound score mnemonic into your brain. It perfectly tracks the clinical progression. Additional treatment with antibiotics, serous discharge, erythema, purulent exudate, separation of deep tissue, isolation of bacteria from the wound, and a stay in the hospital that is prolonged. Easy to remember, right? Section 4, the 4 wound categories calculating the risk. A truly great surgeon anticipates an infection before they even make the first cut. We classify every single surgical wound into one of 4 distinct categories to predict infection rates and dictate our antibiotic protocols.
This table, right here, it's your ultimate cheat sheet. A clean procedure, think thyroid, breast surgery, or an uncomplicated hernia, carries a tiny 1 to 2% risk. Antibiotics are rarely needed unless you're placing an implant. But look at what happens the second you enter the GI tract. Even in a clean, contaminated elective cholecystectomy or prepared bowel, the risk hits 3%, and antibiotics are definitively required. A contaminated emergency, like an obstructed bowel, the risk shoots to 6% with antibiotics, and you absolutely must continue them post-op. Finally, dirty wounds, fecal peritonitis, and abscess, the risk sits at 7 to 8% even with antibiotics, which you've got to use pre-op and continue well into recovery. When we're talking dirty wounds, timing is absolutely everything. Please do not confuse the golden hour of trauma with the 4-hour decisive period of wound colonization. Once the skin is breached, bacteria need exactly 4 hours to colonize. This incredibly precise timing is exactly why we give prophylactic antibiotics before we make an incision. We want peak tissue concentration during this critical window. The golden period, on the other hand, is the 6-hour window before a traumatic, neglected wound is officially stamped as dirty. Let's test this in the real world. You've got 2 clean cases on your OT list. A 70-year-old diabetic female for a lumpectomy and a fit 40-year-old female for a mastectomy. So who goes first? Well, common sense dictates you prioritize the 70-year-old diabetic patient. Why? Clean cases always go first to prevent cross-contamination, sure, but among them, you really want to minimize fasting time for elderly patients with comorbidities.
Section 5. Preventing infection. Part prep from scrubbing to shaving. Let's look at how all this theory builds into the physical, hands-on protocols, starting with the surgeon's own hands and the patient's skin. Hand hygiene is, without a doubt, the single most important factor. These are the WHO's 5 moments: before touching a patient, before any clean or aseptic procedure, after exposure to bodily fluids, after touching a patient, and after touching their surroundings. Your surgical scrub has to last a minimum of 2 minutes, and while alcohol rubs are fantastic, remember this golden rule. If your hands are visibly soiled, or if you've just used the toilet, alcohol rubs fail completely. You absolutely must use soap and water. No shortcuts. Now for prepping the patient's skin with chlorhexidine and alcohol. The abdominal prep rule is simple. Clean from the midline to lateral, and discard the swab after each outward pass. For a female patient, prep from the inframammary crease to mid-thigh, and for a male, nipples to mid-thigh. But notice the thigh and perineum prep rule. It's the exact opposite. You clean from lateral to medial, always approaching that dirty perineal area last so you aren't dragging bacteria upward. Oh, and a massive update here. Never ever shave a patient's hair with a razor. It causes these tiny microcuts that just breed infection. Always use electronic clippers instead. And circling back to those prophylactic antibiotics, the absolute best time to administer them is exactly 30 to 60 minutes before the surgery even begins. If it's a grueling, prolonged surgery, you've got to stop and re-administer a fresh dose every 4 hours to keep that protective shield up. Section 6. Perfecting theater protocol. Controlling the environment. Because ultimately, the operating theater itself needs to be strictly weaponized against bacterial colonization. Every little detail here is calculated. The temperature must sit strictly between 18 and 22 degrees Celsius. Why? To prevent patient hypothermia, which is a massive predisposing factor for infection. We supplement this by actively warming the patient with a bear hugger. Humidity sits at 50 to 60%, so the surgical team isn't sweating into the wound. You need at least 4 fresh air changes per hour and a positive pressure environment of +2 millimeters of mercury. That way, when doors open, clean air blasts out and dirty corridor air can't sneak in. Finally, the air quality is maintained with ultra-clean laminar airflow, filtering out 90% of particles larger than half a millimeter. Here's a fantastic, modern clinical pearl you can take straight to the wards. Use a dual-ring abdominal wound protector. They drastically reduce SSIs by shielding the incision edges from the organs. But listen, if you ever see someone washing the cavity with betadine or antibiotic solutions at the end of a case, you need to stop them. The latest data proves it just doesn't work, and it actually drives up antibiotic resistance. Stick to simple, sterile saline.